Is it tomorrow?
Well, today, but I started last night. Oh, just wondered. I'll let you know one way or the other. He said it's all handwritten. He said if you guys want it off the computer, I'm not your guy. Well,
all right. Good morning, everybody.
Since we had those difficulties there.
Want to apologize for our decor here today. We're having some technical difficulties with the equipment, but it's already been ordered and being taken care of through our information technology department. As everybody knows, Arkansas Children's Hospital is now open in Springdale, as you can see in there. I just quoted a conversation we had at Arkansas Children's Hospital because the question has come up several times: will we be transporting to Arkansas Children's Hospital? This hospital was built as a full-service, low-acuity pediatric community hospital. We have to use the resources wisely, and opening a small hospital does not allow for us to push the right size. We're being thoughtful about how we expand to allow for critical care. It's nearly possible to start from the ground up to add a critical care unit, but over that time we'll get there.
I got a question on that. Have you heard, are they going to put a helicopter here?
It's in the 3-year plan.
Okay. But it's not something that's going to happen this year or next year?
At the last meetings we had about 2 months ago, not this year. But these plans are always evolving and changing, and so it might be. I have heard rumors that they're going to put one before the year is over because they look at how many flights they have, and they've already kind of flying more people down. And they have the 3 helicopters. They might, but it's in the 3-year plan.
So
is their official answer.
Would Mercy, any helicopter here, if we was to call in for a pediatric transport to that facility, would they fly on there?
So
Mercy.
So what they're wanting us to do is they're wanting us to take our patients to the nearest ER and stabilize, and then transfer to the big hospital in Little Rock. They really don't want us transferring anything that's high acuity or critical. They're not recommending it go to the Arkansas Children's because they're going to stabilize and then transfer to Children's in Little Rock. So they say it doesn't make sense to bypass local ERs. They're going to provide the same services that they're going to provide at Children's Hospital.
They have asked Angel One crew members if whoever's willing to relocate to submit their letter that they're willing to relocate. So it is, like Leon said, it is something that they are looking at very critically because they're averaging approximately 3 flights a day from Children's Springdale, on top of 2 to 3 ground units of Children's ground units a day as well.
What's the patient? What are they seeing right now? What's their numbers right now since they've opened? Does anybody know?
I don't know.
In the ER? Are you talking about like in the ER?
Yeah, ER or just are they admitting there?
They are admitting patients, but not long term. So if they're anything really generally over 2 days, then they're not going to keep. They're going to ship those out, or even if they anticipate it's going to be longer than 2 days. But for the most part, they're going to just admit just for observation, like a seizure patient, something like that. But as far as ER, they're seeing anywhere between 30 to 50 patients a day in a 24-hour period.
Wow.
Like Central EMS is transporting there, Springdale's transporting there, but those are the agencies that are transporting there because it doesn't make sense to bypass. And they're low acuity, like have a sick kid or a kid that's sick but doesn't probably going to be admitted to the hospital. They recommend you can bring them there. But if you have any suspicion that they're going to be admitted, you go ahead and go to your nearest ER because it's not worth the delay in care. Then transfer on.
Gosh, that's quite a few that first opening.
Oh yeah. If you build it, they will come.
Yeah, I guess that's the way they say it.
Well, initially on their plan, the level to the phase 2, I think, was 5 years, Coker. Initially, I think the phase 2 was a 3 to 5 year plan. I think with the numbers they're getting already, now they haven't been open 6 months, but the numbers they're already getting is making them talk about 18 months to 24 months stepping up to phase 2.
Okay. Hey, the change of subject right quick, since Station 3 is on here, just so everybody knows, they're working on our radio system today, and they're mainly working out at Station 3, just so those guys are aware that there's going to be a crew out there. I don't know if Greg had passed that on to them, but they're going to be moving the radio system out of Station 3 to that building at the tower, below the tower. They're going to be doing all that today. So, and then changing the microwaves, moving the microwaves, and adding new dishes to 2 towers. So, I didn't know if Greg had passed that on to Station 3 crew or not, since they're on. I think they're on board.
Yeah, they are.
Okay.
Thanks for the heads up.
Sharps containers. We have 2 types of containers. Sharps containers, anything that's touched has bodily fluids on it goes in the red container. The medication container has the black on it, black and gray. The 2 cannot be intermingled. Trash cannot go in those at all. And no cardboard boxes, anything can go in those things, only for medication. So if you have expired epi, you need to open up the epi, throw the delivery device away, and just put the epinephrine in the medication box. Commingling of the contents basically results in a $500 fine to the fire department. You can't put medications in a Sharps container. You can't put Sharps in a medication container. If you intermingle and you put trash in there, they kick it back as a fine as well. So we got to clean those up a little bit. We got nailed with one last month. Fluid bags that are expired, they can be cut open and then poured out in the grass, poured them on the pavement, poured them in the sink. It's salt water. And like Sheedy Ringers, vitamins. I mean, they can go in the trash and then throw the bags in the trash can, not in the Sharps containers. Soft supplies like 4x4s, anything that's soft supply, even IV catheters that expire, that have expiration date on there. When those expire, they don't have any bodily fluids on them. They're not Sharps. They don't need to go in Sharps container. Just throws in the trash can. That doesn't have to. If it's unopened product, it's never touched the body. Doesn't have any bodily fluids on there. It can go in the trash can. On equipment's left at a facility or is transported by another agency. Like if we have a patient that has a back injury, we put them in a vacuum splint or on a backboard, and we ship it off a helicopter to Springfield. On Target Solutions is a form that says equipment left or sent with the other agency. We have to fill that out. It sends an email. It sends an email to me. Also, I forward that to Coker, but we also get to that agency where it went to. We have people there, like if we go to Springfield, Chris Mattis gathers that equipment for us and gets it back to us. Our scoop stretchers are $700 a piece. So if they go up to Mercy and they don't come back, we lose out $700. So we've got to make sure the equipment gets sent off that we get it back. Loop Generation 1's are no longer parts main formed by Physio Control. And so we had one break, but it was fixed for us. It's back in service, everybody knows, but just keeping an eye on those equipment, making sure if you're seeing something that's breaking or see something that's spraying, let us know. We can get it fixed before it breaks.
Have you looked at the other 3?
We've looked at some of them. We haven't got all of them, but we'll make sure we get it all looked at today. Everything looks pretty good on them. I just want to say thank you to all the staff. Everybody's been really good about looking for damage on equipment and giving us, when something's broken, or let us know something to be fixed. We haven't get emails, but we just want to always say, if you do know something, continue to send us emails. We appreciate that help. 27 regional protocols are on Target Solutions, available. When you access to the right, you'll see 3 little dots. If you try to download them from the Google Drive, it won't tell you, it won't do it. But if you just click the 3 dots to say download as, and you can select it and do it that way. You just have to take an extra step. I use the Kindle, and it works pretty good. The pages are all linked together. There's a search bar category in there, and everything works pretty well. The protocol app is at Apple's being reviewed, and then it'll be out soon. We can have medication shortages and medication delays due to the constant change. Please check your city email and looking for those updates as you can.
Protocol app. Do you have Google also?
Yes. Yeah. Google as well. Changes, like always, just always want to reiterate, changes will be attempted to made in batches rather than intermittently. A couple of things we have, Ketorolac Toradol is going to be added to the ambulances, review indications, contraindications, your protocols. I just added the indications and contraindications here. Dopamine, we've had to change the manner we're used to carrying it. We don't get the prefills anymore. Now it's being carried in 200 milligrams in a 5 ml vial. The premix is 400 milligrams in a 250. So if you do that, you're going to have to add 2 vials of dopamine to each 250 bag. Your protocols say, to add the dopamine in with D5W, but we've checked with the ER's Dr. Johnson. you can do it with normal saline. So we're going to go normal saline because D5W is hard to get a hold of as well. All of our normal saline bags, we don't kick it at the 100s right now. They're 4 to 6 weeks out. So if you need fluids, the 250s what we have, we do have 1,000 bags, but if you're going to do a premix or you're going to do your epi drips and stuff like that, you're going to have to squeeze out, just spike your bag, squeeze out 150 to get your 100 in there. The air tracks are in, being transitioned into service. We'll have in-service signature sheets to the stations upon intubation attempts practice. We'll then get those on the trucks. We have Israeli bandages. Now, there's a video in here which you all can click on and see how to use one. It's a pressure dressing, commercial pressure dressing. Real good tool for stopping the bleeding. There's a video added on here, and you'll see that when you do your target solutions. We'll add one to each trauma bag. And this time I'd like to welcome Dr. Sheedy from Northwest Medical Center. He's going to give a lecture on pediatric assessment. Hey, guys, the thumb drive? How do you do that?
Hey guys, my name is Craig Sheedy. I'm the emergency medicine docs down at Northwest. Work at Bentonville and Springdale, so we can interact with you guys quite a bit. So I appreciate all your work. So got some pictures and some slides to go through just about pediatric assessment. I don't have anything all that groundbreaking, but hopefully we'll still help you out. Feel free to stop, ask questions, and try not to take all too long.
Have you seen a change in what Northwest gets with this children's hospital opened up?
I haven't really so much. Maybe there's a little bit of decrease of volume, but for the most part, we're still seeing really the same numbers and the same acuity. And just from what I've seen so far, we still kind of have the same numbers of transfers. And we're still transferring a lot down to Little Rock, even with the new children's hospital opening up. I still don't think they have all the full services they're expecting to have. I mean, they still don't have any critical care, so they're still kind of doing just the basic admissions. So I personally haven't really seen much change. I assume as it gets more established, we'll start seeing less pediatric volume, just people being more aware of it and more familiar with going there. I have not really seen that change yet. So I think it's a good resource to the area, so I'm glad we have it. I think there's a lot of need for it.
Got you clear too, sorry.
Okay.
Laser in the center.
Okay. Thanks.
Thank you.
All right, I figured we just kind of run through some cases to try and make it a little bit more interesting. So first one, we got a 15-month-old female. The complaint is my baby is wheezing and gasping for air. So a set of vital signs. Of course, we always deal with pediatric specific vital signs, and no one can remember these. So really, if you guys carry like a Broslow or a weight-based, that's a way to check for normal vital signs. Anyway, so tachycardic, elevated respiratory rate, sats are a little bit low. Is there a way to mouse with?
Yeah. So you have the finger pad on that keyboard? Yeah. No.
That's right. This is the only one that would probably need a mouse click in the presentation.
No. I can plug a mouse in.
That's right. Okay. That's right. We'll skip this one. So this is just an audio clip. Basically, it's just a kid with croup. And the reason I was starting with this case is people will basically call any respiratory noise at all wheezing, and that's not always the right diagnosis. So I just caution you to actually assess the patient, and when someone says wheezing, don't necessarily kind of pull the reflex albuterol. So in this case, so this is croup. The kid has had a barking, cough, and inspiratory stridor. So croup is different than asthma. Croup is upper respiratory inflammation as opposed to lower, which is asthma or even bronchiolitis. So typically you see this in kids 3 to 36 months. The most important piece of this with upper respiratory inflammation is try to minimize pissing the kid off. The more you make them yell and cry and scream, the worse their upper obstruction is going to get. And so the main thing is just leave them with mom. It's actually best to not try and start an IV because that will make them worse and will make their breathing worse. So try to minimize what you're doing to the kid, really. So the treatment for croup is first and foremost racemic epinephrine, especially if they have stridor. Racemic epinephrine reduces the upper airway edema and helps to decrease the swelling that's causing the stridor and upper airway obstruction. Now that doesn't really have any sort of long-term benefit. It really only helps the kid while they're receiving the racemic epinephrine. But for y'all, basically you should be able to start that and hopefully have it running long enough to get them into the hospital. The other treatment is just a single dose of steroids. We do Decadron. We don't really expect that to you guys give the steroids in the field, but you could. And really any steroid would work. But typically I do Decadron, which is a longer acting. We do 0.6 milligrams per kilogram up to a max of 16 milligrams. And I know that's a high dose, and oftentimes I give kids more than most of my colleagues are comfortable giving to adults. Usually times I'll give 4 to 6 to 10, but really the max dose is 16, and I'll give that in kids. Yeah.
Do you nebulize that, or do you use IV?
The Decadron, I usually have them drink it. So the IV solution can be given oral.
Right.
If the kid has an IV, yes, I'll give it IV, but in the same context of trying not to piss the kid off, usually I'll take the IV solution and just give them to drink it with applesauce or juice or pudding. Yeah, and you can't do that. And so, yeah, a lot of the nurses, I guess, weren't as familiar with that. So I had to kind of reassure them, yes, you can do this. Just give it oral. It works. I promise.
Living for the ambulance.
So there you go. Start stocking that.
For PD related reasons. Nothing to do with it.
Yeah. All right. So in kids, respiratory distress. I'm sure this is one of the things you all see the most and one of the kind of most anxiety provoking sometimes. Kids will usually show you when they're working hard. Parents, sometimes they'll overreact. A lot of parents are reasonable. A lot of times you're like, oh my God, my kid is dying. And the kid's just like sitting there as happy as can be and like sneezes once. Like, yeah, okay. But most of the time, kids, when they're working, they will show you. Typically, they have retractions, so they're pulling really hard within their ribs. If they're really struggling hard, they're pulling with their belly. You get this kind of head bobbing where they're heaving with the head. That's when you should be a little bit more nervous. So you'll see that physically on the kid. Of course, listening for anything abnormal. Stridor, again, upper respiratory, wheezing. If they're grunting, that just tells you they're really working hard to breathe. And of course, if they're tachycardic. So this is just a video. So you kind of see the upper retractions. You can see the muscles flaring within the ribs. You can see the whole belly heaving and pulling. So this is a kid who's already in some moderate respiratory distress. And this kid in particular, that was actually a case of bronchiolitis. So management of bronchiolitis, also a lower respiratory inflammation, usually from a virus. It's not quite the same cause as like a reactive airway or wheezing. It's always reasonable to try an epi or even a duonev on these kids. Oftentimes, they actually don't necessarily respond to that. And they usually don't respond to steroids for this in particular, for young infants. Really, the treatment is upper airway suctioning, if you're able to, and then just support measures, giving blow-by oxygen if their SATs are low. Most kids don't really tolerate like a nasal cannula well, so just doing some blow-by oxygen until you can get them into the hospital. And then for us, with like a bronchiolitis, usually it's just a matter of if they're really struggling, if they have low SATs, if they have respiratory rates in the 50s or 60s, we'll keep them just for supportive measures, but there isn't really a special treatment other than letting the virus run its course. In terms of asthma, I know you guys will see a lot of asthma, and usually you see it so much, you all manage it very well. In the field, it's a matter of albuterol or a duonev, just kind of running it continuous. IV, kind of the same thing. I don't know that it adds a whole lot of benefit in the field, but it's certainly reasonable to try to place. Usually we will give a dose of IV steroids. Yeah. In the emergency department, but the timing of that isn't really that crucial for you guys to worry about doing in the field. So just in terms of evaluation, so my general approach, and this is kind of true of adults and kids, but just overall, how do they look? So just kind of your gut feeling. And of course, with experience, you should have a good idea of that. That's just looking at the kid, looking at their retractions, seeing how they're pulling, starting with the respiratory. So of course, for every patient, we talk about ABCs. And in my training, our initial evaluation of every patient was ABC, NGT, and 5. So ABCs, of course, is your...
I just unplugged you real fast.
Oh,
I'm
you're
sorry.
killing me.
I was trying to be fast about it.
Whoa.
Somehow our thing just kicked out.
The man on the moon. So I know that several years ago,
It's like NASA here,
stepped
right?
up there, pediatric board, I guess.
Yeah.
Has that maintained pretty well, or?
Pediatric floor
Yeah.
in the hospital.
Yeah.
Yeah, we closed our pediatric floor. So we have no pediatric admission capabilities in our system anymore. Yeah, so before the new hospital opened, we actually had a transfer agreement. The kids from Bentonville would transfer to Mercy Hospital. The kids from Springdale would go to Washington Regional Medical Center.
They're so small, you can pretty much put them anywhere.
Yeah. Stay in a corner somewhere. Yeah, so our pediatric numbers were decreasing, and with the expected opening of the new children's hospital, they basically decided it wasn't worthwhile to maintain a pediatrics unit. So we actually don't admit any kids. Of course, we're always happy to see them and stabilize them. But yeah, we don't admit children to either hospital anymore, and that change occurred just a couple months ago. So yeah, unfortunately, no pediatric admissions at all at our facilities.
And all the excitement, Dr. Sheedy, they're having the regional disaster drill right now.
Oh, is that right? That's
That's
today?
why I said I was going to be a little late.
Oh, dang.
And then, of course, as soon as they walk out the door, they page 2 level 1 traumas for the drill.
Yeah, I didn't know that happened today. I would have liked to have seen it.
Okay, now you're good.
All right, so you know, basics of medics or emergency department, it always still comes back to ABCs: airway, breathing, and circulation. That's basically what you got to stabilize. So for airway, if it's an older kid, I'll basically just ask them to tell me your name. If they can talk, airway is pain. Okay, kids gonna be a little bit harder to assess, but if the kid's yelling and screaming at you and crying, excellent. That's an open airway, so that already decreases your concern there. Breathing is basically the things that we talked about, looking at how fast they're breathing, how much they're pulling, looking for retractions, pulling with their belly, looking for equal symmetric breath sounds. Of course, it's always worth listening, especially in a trauma patient, to make sure you don't hear any evidence of asymmetry that would suggest something like a pneumothorax. Circulation grossly is, of course, do they have pulses or not, right? Is their heart beating or not? In kids, typically we feel for a brachial pulse. In older kids, you could feel for a radial. Of course, you can always check for a carotid. Finer details is looking at capillary refill. It's a little bit sluggish. Is it greater than 2 seconds? Not really as important. Is their heart beating or not, right? Usually you can tell that by looking at the kid. We add in disability and exposure. So disability to me is sort of a neurologic assessment, getting a gross idea of what their GCS is, disability in terms of thinking about seizure management, disability in terms of trauma, it's like if there's an obvious deformity or fracture, stabilizing it. So just kind of basic. And then E, we talk about exposure, and that's more for trauma patients, getting them fully exposed, making sure you're not missing any injuries. Especially in the case of penetrating trauma. Certainly don't necessarily see that as much in kids and not in this area, but I did recently have a 14-year-old boy that was stabbed by his brother because he took his shoes, like literally stabbed with a knife. So with that, a lot of times, even if they report a single injury, the kid had told me he had a single injury, and then on my assessment, he had a second stab puncture injury to the back of his head that he didn't even report that was there. So if you can, just do a quick sort of expose them, kind of, if you're able to just do a log roll, look at the back. I mean, you know, we see gunshot injuries in kids. One kid accidentally shoots another. You want to try to identify all the injuries, even in the field or in route, because that helps you all and us all know kind of what to expect, what their clinical course may be. And then history in general, we just talked about an ample history in emergency medicine, just getting the basics. So allergies, medications, past medical history, last meal or last menstrual period, and then the events. If you're able to at least get the basics of these pieces of information, that's always really helpful for us. You know, if you can just hit the highlights of this, even when you're giving a report over the radio, it helps us know what to expect if it is something that's kind of serious or more emergent. In particular, the events, sometimes there'll be like multiple family members at home, and then like one person comes in, and it's sometimes better to get more information. But again, you don't want to delay transfer for that in particular, but that can be helpful for us. All right, so dispatch number 2, we got a 4-year-old female. The complaint for y'all is she can't stay awake. Here are your vital signs. Any questions? What do you want to know about the patient? Any of those vital signs stand out to you? Yeah, good deal. What's a normal respiratory rate for kids?
Like 30 something.
Yeah. Yeah, it's definitely higher than adults. For young infants, respiratory rates in the 40s actually can be normal. For kind of infants or adolescents, even in the 30s or mid to high 20s are normal. All right, so on your overall assessment, you got a girl, she's kind of somnolent. She'll kind of wake up for you and fall right back asleep. She is breathing, but slow. She's got equal breath sounds. She's probably about a GCS of 14. Anything else on exam that you think would be helpful to you in evaluating this patient? Events? Yeah. So patient is staying with grandma. Grandma said, I don't really know what happened. You know, earlier today I spilled out my pills, and then about an hour later she just couldn't stay awake. Yeah, so she's had narrowed or constricted pupils. And so looking at the eyes in someone who's altered is always a good idea. If they're even comatose, of course, trying to get light out and look at their eyes. Looking for those constricted pupils can really give you a good idea. So yeah, ample history on this one. Really nothing significant other than staying with grandma, and they said she spilled her pills out. So kids get into anything and everything, whether they find it on the floor or whether they find an open pill container, a bottle, they will take it. Yeah. So this was actually opiate overdose. The kid had basically had a tablet that they found on the floor of hydrocodone and took it, and actually did develop symptoms of the respiratory depression, somnolence. Okay. So what's your treatment going to be for this? Narcan, excellent. We know Narcan, we love it. So that gets into so in your overall assessment of a patient, going back to basics, every patient, every time, ABG, NGT, and then 5. So NGT is your Narcan, glucose, and thiamine. Any patient with altered mental status, you've got to think about these 3 things. The first 2 are probably the most important. So Narcan, any patient with altered mental status, pinpoint pupils, slow respiratory rate, think about it and or just give it. The main side effects, sure, if they're opioid dependent, they can have withdrawal symptoms. Will it make them feel miserable? Yeah. Will it make your life miserable? Yes, it will. But most of the time, don't see young kids that are actually addicted or dependent on opioids. So really, you're not going to get any withdrawal symptoms. Of course, in older adolescents that could be abusing these drugs, sure. Glucose, also very, very important. Always check that altered mental status. Seizures, always check it with seizures. That's really key and something that can be easy to miss. Generalized weakness in kids, holds true for adults, but kids as well. Thiamine, less likely in kids, but we do see a lot of kids that have chronic medical conditions that still can have poor absorption. So thiamine, also mental status, thinking like a Wernicke's encephalopathy. Do you guys even carry thiamine? Yeah, so not as important for you guys. So, but Narcan and glucose, always think about those two. And obviously you guys usually know that and do a good job with it. So Narcan in general actually can be used to reverse a lot of things. A lot of things act on the opioid receptors more so than just opiates. And so there's actually a long list. In particular, this was kind of the grouping that I try to remember. Someone made up a dumb mnemonic at the top, which is rock, lava, Z, but opiates, clonidine, Lomotil, ACE, ARB inhibitors, you'll see all of those the most. Valproic acid, and not too many people are on that these days. Methyl-dopa, again, I don't know if you could be into grandparents' meds or something. Someone with Parkinson's. Xanaflex, we still see a lot of as a muscle relaxer. So in particular, clonidine is around a lot. A lot of people have that at home for blood pressure meds. So asking about that, if you get that history, if you're altered or obtunded, actually doing Narcan can help to reverse the effects of that. Lomotil, there's actually more abuse of Lomotil now, and especially people that are addicted to opiates, because it does act on the opiate receptors. So you get some benefit from that, and people use it for anti-diarrheal if they're having opiate withdrawal. So some people are now overdosing on Lomotil when they can't get a hold of their narcotics. Then ACE and ARB inhibitors are everywhere. So everyone's on those for their blood pressure, and kids can get into those or having overdose. So actually Narcan can help to reverse the effects of those. So that's not something that you necessarily hear about as much, but if you can remember it, that is a treatment that can help and provide some benefit. So you could start that in the field. All right, dispatch number 3. You got a 15-year-old male calling as he collapsed playing basketball. He isn't breathing. All right, so you get on scene, and these are your vital signs.
That looks good.
Yeah, excellent. So there's kind of one of these perks about emergency medicine is that the simpler things are, is the sicker they are, right? So in this kid, what are you going to do? CPR, great. It's easy, right? Don't have to think about it too hard. All right, so really we do ABCs. When we talk about arrest, most of the time in kids, it's often a respiratory arrest. So really, we usually recommend still starting with respiratory management, providing ventilations first. And now in practice, yeah, you're going to be doing these things simultaneously. Of course, start compression as soon as you can. Someone can start ventilation by some means. We'll get to that. All right. So you're able to get a quick rhythm strip, and this is what you see in this kid. Now what do you want to do? Electricity. Shotgun, right? All right, so I'm not going to go through all of PALS or BLS, but this is basically what this case is, right? So you're going to start chest compressions. If you're alone or by yourself, the recommendation is 30 compressions to 2. In kids, if you have 2 people, we usually recommend doing 15 to 2. So 15 compressions to 2 breaths. Now, most of the time, we kind of just do continuous chest compressions and then ventilate at the same time, which I think is reasonable. I think the evidence says it's not really better or worse in terms of outcomes, including neurologic outcomes. Okay. So in kids, if it's a shockable rhythm, of course, defib, you shock them. Again, using a weight-based or like a Breslow measurement is the way to go. Start with 2 joules per kilogram. You can go up to 200, which is the adult dose. For y'all, just doing the adult pads, or if they're touching or overlapping, using pediatric pads, okay? Of course, maintaining high-quality CPR in between. All right, so in our cardiac arrest, so airway management. Your goal is to provide ventilation, all right? What is the best way to do that? The fastest way, yeah. That's exactly right. So bag VASC ventilation works, and it works the best. Sure, it's sexy to intubate the patient. It really actually is oftentimes worse trying to intubate the patient than just doing bag mask ventilation with something like an oropharyngeal airway or a nasal airway. So this has actually been studied quite a bit. In most of the studies, yeah, there's mixed results, but there's actually decreased mortality with bag valve mask ventilation compared to intubation in the field. And then doing just an LMA or a supraglottic airway actually has greater success than intubating. And kids are usually easier to ventilate with bag mask than adults. Usually they're not as in terms of obesity, neck, facial hair, beard. Usually you're not running into those problems as much, especially young kids. They're usually easy. A lot of times you can do it with just a single hand. You can get a great seal versus adults, big faces, big jaws. Sometimes you need two hands. So really, if you can ventilate them with bag valve mask, then that's great. You can stick with that through the whole transport until you get them in. Part of that is pediatric intubations are a little bit more difficult. They're usually smaller airways. They're more anterior. Usually there's more anxiety associated with trying to intubate a kid. I know y'all are very good and have a lot of experience intubating, but even in the best of scenarios, sometimes it can be difficult and you're in the field with less than ideal situations. There's actually greater risk and less likely success rate. So sticking with bag valve mask really is great and probably the way to go. All right, so this particular case, this is actually a case of hypertrophic obstructive cardiomyopathy, right? So this, you don't see it very common, but it does happen. One of my really good friends, his brother died 15 years old this exact way. So usually what it is, it's a genetic disorder. It's autosomal dominant. This is the young, healthy kid playing sports that dies suddenly, okay? And it's awful, awful when it happens. Just in terms of mechanism, you get hypertrophy of the interventricular septum or the left ventricle outflow. So in times of high flow rates, you cannot get a good flow out of the left ventricle, and that predisposes you to dysrhythmia or atrial fibrillation. The treatment for you all is still, ventricular fibrillation. The treatment is still electricity first, okay? So in terms of airway, breathing, circulation, so we're ventilating this guy with bag valve mask, okay? We shock him, and it's not successful, okay? Now what do we want to do? CPR? Continue CPR. All right. In terms of thinking with ACLS, right, so we've got a VFib arrest now. So now we've shocked him, it hasn't worked. Now we're going to think about additional therapy. So yes, continuing CPR, continuing ventilation, continuing to shock every rhythm check if it's a shockable rhythm. But of course, using medications, right? So now we're thinking about, if we can, getting IV access. If he's 15 years old, yeah, potentially he has a good vein you can get. And still for kids, doing epinephrine according to advanced life support. So for kids, you usually recommend 0.01 of epinephrine milligrams per kilogram. Again, using a Brosler weight-based is the best way to do it. Actually, giving a fluid bolus in this particular case helps. If you increase preload, meaning you increase volume, that gets you better outflow from the heart, so using a full fluid bolus. I wouldn't necessarily expect you guys to know that, but in this particular case, sudden cardiac arrest from a healthy kid, fluids will actually help. It helps to increase the ability to outflow when you do get a rhythm back. But yeah, just continuing PALS. All right, dispatch 4, different case. Got a 2-month-old female. The complaint is my baby is having a seizure. So you show up, these are the vital signs. They're tacky, they're tachypnic, sats are a little bit low, they're maybe starting to turn a little bit blue, and this is what you see on your little baby. So what do we think? Is it a seizure? Looks like one to me, yeah. So babies can be hard. Sometimes they don't typically have the generalized sort of tonic-clonic movement or twitching. So sometimes it really can be hard to tell. Sometimes kids will just have the kind of repetitive blinking of their eyes, or just kind of that kind of tongue writhing or lip smacking without the other stuff. So babies can be tough. Sometimes it's hard to tease out, is it truly a seizure, is it not? Any concerns, yeah, you should treat it like a seizure, okay? All right, so you show up at home, baby is actively seizing. It's been going on for 7 minutes continuous now, okay? All right. So breathing's okay. Sats are a little bit low. So again, assessment every time. ABCs. All right. So we'll kind of do the same things we've been doing. So airway. Yeah, I'd go ahead and start some bag valve mask ventilation, or at least blow by oxygen so you can get those sats up. Baby is breathing, but again, you can support them. Heart rate's a little tachycardic. We often see with the seizure. She's got bounding pulses. All right. So ABCs are okay. You're providing some ventilation support. So D, disability. So how do you want to treat this seizure?
Squirt a little Versed in the nose.
Yeah. Yeah, that's a great thought. So we talked about kind of the Bresla using weight-based tape. Is this what you guys use on the trucks?
Anti-heavy.
Do you? Okay. Yeah, which is similar. So basically, this is an easy way, again, to just estimate the dose. So Versed, however you give it is fine. If you have an IV, you can give it IM. You can give it sort of oral or tracheal. IM really works just as fine, all right? So you give your dose, okay? There's no response at all. No response at all. Baby's still seizing. Now what do you want to do? Another dose? Still doesn't work.
Let's go to the hospital.
Go to the hospital.
Give a dose on the way to the hospital.
Yeah, more doses. Still not working. All
I
right.
mean, as long as it's sat okay, I mean, kids sees.
Yeah.
That's a big deal.
Yeah. So going back to our assessment, so we talked about ABC, NGT, and five vital signs. All right, what's our NGT?
Thiamine.
Yeah. All right, so let's check a finger stick glucose on this baby. It's 18. Now what do you want to give?
10.
Yeah. Glucagon, dextrose, you want to give it some way, right? That's great. In kids, in an emergent situation, doing an IO is really the best, all right? It gives you good vascular access. It'll still work faster. Glucagon would work, but actually giving dextrose would, to me, still be preferred if you can get quick access. In kids, IO access is preferred to the proximal tibia. You go 1 centimeter inferior and medial to the tibial tuberosity, which in kids or anyone, you should be able to feel. So basically on the shin, go 1 centimeter down and over, there's a flat area of the bone. That's the preferred place to put in an IO. Do you guys carry just like a hand drill IO or an easy IO? Easy IO, yeah, perfect. So in young babies, I'm not gonna look for an IV anywhere. Maybe one of our best nurses can find it, y'all could, but IV access in little kids, especially a seizing kid, is gonna be near to impossible. So if you're able to, I would actually recommend just doing an IO, okay? You can just hold them down, you should be able to get it in place. Or doing IM glucagon or another is a great source. So in this patient, thinking about our ample history, these are tough. I mean, half the time you're not gonna even know to ask these questions or know what's causing it. This was an infant. Their family actually couldn't afford formula, so they were diluting their formula out with water. So this kid was actually hypoglycemic from poor oral intake from dilute formula. Not like you're going to see this very often. This would be very unusual, but still, if they're not responding to benzos, you got to think about alternative causes. And glucose, always should try and check a finger stick glucose in any patient with seizures, okay? All right, I threw that one in there just to trip you up a little bit. So in dextrose, again, using sort of a weight-based or estimate is great. I try to just remember this. This is one of the ones I just try to remember, not have to look up. So usually I think about infant, child, and adult. You are increasing your concentration. So for an infant, you want to do D10, child D25, and adult D50. When you multiply the two numbers together, it should add up to 50. So if you're doing D10, it should be 5 mLs per kilogram. If you're doing D25, you're giving 2 mLs per kilogram. If you're giving D50, 1. Again, you can always stop and look at that real quick. That's, I find a fairly easy way to remember and then give that IV or IO. And to me, really, that's a preferred way if they're hypoglycemic to get them up. So seizures. So our initial assessment where I trained was ABC, NGT, and 5, right? It's hard to remember causes of anything and everything. We try to always simplify things down into 5 groups. This is something that we would repeat over and over and over and try and remind ourselves of. So is this something y'all are gonna recall or be exposed to? Not necessarily, but this is just how I remember it. So 5 causes of seizures. We always try to group things in 5 to make it easy. So vital sign abnormalities, so hypoxia, okay, that can cause seizures. Febrile seizures. Think about toxic or metabolic, so hypoglycemia, even kids or adolescents. Hyponatremia. Okay, structural, is it a bleed? Is it a mass? Is it a trauma patient that's having a seizure? Is it something infectious and an epilepsy? Some of these things you guys can start to address in the field. Some of them, yeah, of course. I mean, are you going to get a CT scan and confirm that they have head trauma or a bleed? No, of course not. But I just thought I'd throw it out there. So not all seizures are just epilepsy or they're prone to seizures. So some things actually have a specific cause that we need to reverse, okay? In terms of specific causes that we have to reverse, again, we've got 5. So causes that need a specific antidote other than just benzos. So hypoxia, obviously you should check the vital signs if they're hypoxic, give them oxygen. Hypoglycemia, of course, dextrose, we talked about that one. Hyponatremia, this is one that you guys probably aren't necessarily going to be able to find, but that's a specific seizure that needs to be treated with hypertonic saline, okay? So I guess still something for y'all to consider if you've tried all the other options. If you've got a long transfer time, if the kid is still seizing, yeah, maybe call medical control. That would something to consider. Do y'all carry hypertonic saline? No? All right, well, never mind. Isoniazid, again, that's not something y'all can deal with, but vitamin B6. In some of our Marshallese kids, you actually see patients that have tuberculosis that are on isoniazid. Again, certainly still not going to be very common, but isoniazid, overdose or toxicity, most commonly used for tuberculosis. That's something that needs a specific treatment. And then eclampsia, again, gosh, we see a lot of 14, 15-year-old girls that are pregnant and don't even necessarily know they're pregnant. So that's another cause of seizures. Where I trained, our medics actually carried magnesium. Y'all carry magnesium on your trucks? No. Okay, never mind.
Well, yes, we do. Yes.
Yeah. So again, probably just get them to the hospital as quick as you can, but those are specific seizures that aren't necessarily going to respond to your benzos. So got to think about for other causes. All right. Dispatch number 5, got a 6-year-old male. He wrecked his bike. Patient is confused. Says his belly hurts. Those are his vital signs. So the kid's awake. He is breathing. His respiratory rate is actually normal. He's got bilateral, clear breath sounds when you listen to him. A little bit tachycardic, stats are fine. Blood pressure is fine. So we think about pediatric trauma. There's some specific things we think about for trauma in general. Actually knowing the mechanism helps you kind of know what injuries to expect, right? In terms of blunt trauma versus penetrating trauma. And even in the field, there are some things that y'all need to be able to do, right? So if you're thinking about penetrating trauma, all right, we're thinking about hemorrhage control, if it's something external, if it's an extremity, putting on a tourniquet. If it's penetrating to the chest, you know, especially if it's a arrest or peri-arrest situation, doing a needle decompression, okay? Even in kids, that's something that would be for y'all to do in the field, at least to try, especially if it's a trauma arrest. That's one of those things that, yeah, you could fix it. If it's trauma arrest, if it doesn't work, yeah, they're likely not going to make it. Have any of y'all done a needle decompression of the chest? Yeah, good. So the recommendation is still the second intercostal space in the mid-clavicular line, so beneath the clavicle, on soft space there between the ribs, okay? And that still should work. In adults, there's actually greater success, and part of it has to do with the depth of subcu tissue, not as relevant for pediatrics, but actually going basically at nipple line or fourth intercostal space in the mid-axillary line. That's where we do a chest tube. And actually there's decreased on most people adipose tissue, so your increased likelihood of actually getting the needle into the thoracic cavity for something like a pneumothorax or tension pneumothorax. So that'd be something to consider, especially in a penetrating trauma. So back to this case in particular, so there is a specific injury pattern that's typically associated with bicycle injuries, believe it or not. So usually what happens, they hit something, the wheel turns, they get slammed in the abdomen with the handlebar. Oftentimes they're thrown over the bike, and then we'll have a resulting head injury. And so that helps us think about what injuries are going to be. In terms of abdominal trauma, you think about sort of splenic injury, you can get a duodenal hematoma. If they're hypotensive with splenic injury, again, IO access, and then fluids as needed.
31, I have a ball injury, number 4, Kingsdale Lane, timeout 10:31.
All right, so trauma in general for kids, head's larger, so higher frequency of brain injuries, including C-spine. What are y'all's protocols for C-spine immobilization? I know some of the medics really don't immobilize anything.
So we're gonna get a C-collar, if it's spinal neck injury.
Yeah.
Then neck pain, they're gonna get a C-collar, and then we're going to use the backboard to get them to the stretcher.
Yeah.
And we're going to then immobilize, injury.
Yeah, perfect. I agree with that. So some of the medics had said they're moving towards not placing C-collars, and basically said their impression is that any damage that was going to be done is already done, so you're not really protecting them by placing a C-collar.
Yeah, we use the soft splints.
Yeah.
We use it's a vacuum splint C-collar.
Okay.
It fits off, so it goes on there, and then
Yeah.
it's
Perfect. Yeah. I still recommend it in any injury, or especially head injury. I would recommend doing immobilization and spinal precautions. I have seen cases where patients had an unstable C-spine fracture that came in, moved in their legs, and at some point during their evaluation, transected their spinal cord. And so, so this was some of the other medics, not in the area here, but they basically said they stopped all C-spine immobilization, and that was their protocol. I was just curious, but I do recommend it because you can have a unstable C-spine injury that if you're not careful, you can cause further damage. So in kids in general, skeleton is not fully calcified, so sometimes you have organ damage without bone fracture. So it's still important to think about that. Sometimes kids will actually look great, but still have underlying injuries, even without any obvious external bruising or deformity. And then hypothermia in kids can develop quickly, so trying to keep them covered, keep them warm. Yes, I talk about exposure. We want to see them. We want to evaluate for any possible injuries or penetrating injuries even prior to arrival in the hospital. But then if you can, cover them up or try to keep them warm. All right, dispatch 6, 18-month-old female. She's got an awful burn to her bottom, calling the bathtub, scalding water with stepdad. That's what her burn looks like, okay? So airway, breathing, circulation are intact in this baby. No immediate concerns there, okay? Anything stand out to you about this injury pattern?
Yeah, that doesn't look like a scalding hot bathtub.
Yeah. Yeah, so you can see there is no burn kind of to the very bottom of the buttocks, and it's all around the groin and the thighs. So this was, in fact, from a bathtub burn, and this was from someone holding the child down in scalding water. There's no burn to the bottom because it's pressed against the bottom of the bathtub. All right. Sometimes you'll see cases like this. Often in terms of burn injuries like this, it's like potty training, like the kid is wet their diaper, they're not supposed to, and an angry or upset parent will punish them by something like this. So this was actually a potty training punishment by intentional burn. So even for y'all in the field, again, making sure the reported mechanism is consistent with the injury pattern. So you have to always consider child abuse, which the new term is non-accidental trauma, child abuse. Y'all probably wouldn't run into this much, okay? But if you suspect child abuse, even if the family or guardian tries to decline transport, basically you have the right to call police enforcement and mandate transport. And we can get a court order for it. But even if parents try to decline, if you suspect child abuse, don't just let them decline and leave. That does happen sometimes, or parents will try to let them leave to cover up or protect themselves. So hopefully you don't run into that, but it's something to be aware of and think about. And kids, I doubt they're often trying to decline transport, but very, very important if that's something y'all run into call the police, call medical control. They have to come in for evaluation. Okay, and we have to notify, make a referral to Child Protective Services. All right, so next one, got 9-year-old male, got rash and wheezing, and that's what you see when you look at him. All right, vital signs are roughly okay. Sat's a little bit low, breathing kind of fast. You listen to him, he does have wheezing throughout his lungs. All right, what is this? Yeah, perfect. So this is another illness where time really matters, okay? So my definition of anaphylaxis, it's kind of hard to define, right? For me, it's an allergic reaction with more than one system involvement. If they have hives and wheezing, if they have hives and nausea or vomiting, if they've got hives and if they say they feel short of breath, to me, that is anaphylaxis. You give epinephrine, okay? The number one reason where people, kids or adults, die in anaphylaxis is the failure to give epinephrine. And kids usually don't have a whole lot of comorbid medical conditions. Sometimes in adults, we worry about giving epinephrine. They got CHF or cardiac abnormalities. In kids, oftentimes you don't have that. If you have any concern for a serious reaction or developing anaphylaxis, you need to give epinephrine, okay? What's the preferred route for epinephrine in anaphylaxis? IM. Yeah. Actually, IM. Even if you have an IV, if you have an IO, I still actually recommend giving it IM, okay? My program director used to say there's 2 times you want to give IV or IO epinephrine. 2 times and 2 times only. If the patient's dead and you're trying to make them alive, or if they're alive and you're trying to make them dead. So IV epinephrine is very, very prone to causing dysrhythmias, even at the lower dose given for anaphylaxis. So I'd always give it IM. It's still rapidly taken up, will work quickly within a couple of minutes. Okay, but I'd still give it IM. All right, so back to set to 5. Oh gosh, we've got set to 5 for everything. So for anaphylaxis, number 1 is epinephrine, okay? 0.01 milligrams per kilogram IM for a child. If you can't remember that, EpiPen Junior is 0.15 milligrams, so you can give that dose for pretty much any child. The adult dose is 0.3 milligrams IM for any adult. You can repeat that within 3 to 5 minutes if they're still symptomatic. Other therapies that help if you have an IV access or have a way to give it is Benadryl, a histamine H1 blocker, an H2 blocker, it's a histamine 2 blocker, that's like Pepcid or Zantac, that works on the GI tract. Giving steroids of any variety, and I'll typically do Decadron, giving steroid, and then a fluid bolus. You vasodilate so you can get some hypotension related to the histamine release. So about 5 treatments for everything, just to make it easy to remember. We like groups of 5, but epinephrine is the one, and you gotta give it or they'll get worse. Their throat will swell, and people do die from anaphylaxis. All right, a couple more quick ones at the end. So, gosh, kids do stupid things. So, 8-year-old male, so eye pain after doing the Tide Pod Challenge. We all seen this Tide Pod Challenge? Gosh, there's so much stupid stuff on the internet. But in general, this is you put Tide Pod in your mouth, you either chew on it or bite it, and then like spit out the detergent. What idiot thought of that? I don't know, but people are doing it everywhere. So, normal vital signs or whatever, this is what the eye looks like. Of course, you're not gonna do a fluorescein stain, but so these Tide Pods or these detergent pods, we're seeing a lot more exposures and injuries from these, and they can cause some serious damage. In particular to the eyes, okay? They're very alkalotic. They cause alkalotic burns to the eyes, which are even worse than acidic burns. In addition, they have surfactants, so they're trying to, obviously, when you're washing your clothes, you're trying to make something that will dissolve sort of lipids and water. So anyway, very, very, very damaging, and you can get very serious burns. So as soon as you can start irrigating this, the better. And this is something you can even start in the field, and it really would prefer that even if you can, before you get them in. So just starting to irrigate with just a bag of saline or water or lactated ringers, whatever you got, but just irritating the crap out of it, okay? These can cause serious damage. And as I was looking for that, I found this article. So teens prefer snorting condoms to eating Tide Pods. So apparently this is another
This is new.
This is another challenge. I'm like, what the hell is this now? Jesus. So apparently stick a wrapped condom in their nose and try to snort it and suck it out their mouth. And again, what idiot came up with
They'll
this?
floss with it.
Hell if I know.
Yeah, they're trying to floss with it, like a spaghetti noodle.
So,
Leon, you know a lot about this.
Huh?
You know a lot about this.
It's popping up on the watch list for feeds because they're snorting and getting stuck in the back of the throat.
Yeah.
Anyway. So you're going to innovate. What is this back here? And you're pulling a condom out.
out of the back of their airway. It's just unbelievable. So, if this is the preferred way to use a condom these days, that's just it is to me. All right, so I mean, most of this is probably nothing groundbreaking to y'all. So for y'all, really just stabilize anything emergent, and which is ABCs, but yeah, DE, disability in terms of neurologic assessment, altered mental status, seizure management, and then really the key takeaways are ventilate, bag valve mask works as well as anything, right? Knowing how to treat upper versus lower respiratory distress. If it's upper, it's respiratory or nebulized epinephrine. If it's lower, yeah, trial of albuterol is always the right thing if it's a reactive airway disease or bronchiolitis, and then getting them into the hospital, all right? And most kids, if they're gonna arrest, most of the time it's a respiratory arrest. So those are the things to always focus on and be comfortable with. C, cardiovascular, I mean, of course, just knowing the advanced life support, compressions, shock, meds as needed. And then seizures, thinking about other causes other than just sort of epilepsy or just giving Versed. So think about the things that need an antidote, in particular glucose. Should always think about that, because that's something that really could be fatal or life-threatening if sort of missed or not corrected. So always checking a finger stick glucose in all seizure patients. So ABC and GT, and just making sure you get a full set of vital signs and trying to address any abnormalities. Yes?
And isn't it pretty important to test it with on all kids that are under a lot of stress? Because they're really prone.
Yeah, and that's always a good idea. So kids have less glycogen stores within their liver, okay? So even if you give glucagon, they don't necessarily respond to it as well as an adult. We're talking about glucagon. So oftentimes they have decreased stores and decreased ability to compensate when their body is stressed. And so, and I mean, you can see hypoglycemia with any severe infection, with sepsis, with any kid that's been thrown up for a couple of days. So, you know, it's something that's relatively famous. I mean, kids, any needle poke, they're going to freak out about it. But that's something that probably is worth checking in a variety of cases. But any altered mental status, any confusion, even with the severe infection, it's worth checking and thinking about. Questions? Any other particular questions for pediatric assessment? Gosh, it's such a broad topic, and there's so many things that y'all see. I mean, you're never really going to be prepared to know or see or treat everything, but at least falling back to the basics: airway, breathing, circulation. Okay, starting to address particular complaints. I mean, even if it's something like the high pod in the eye, yeah, flushing it out. Of course, if you ever have a particular question about should you start something or treatment or just get them into the emergency department, of course, call medical control for any further recommendations. But I don't know if that's helpful, but that's kind of what I think about when I'm looking at and evaluating kids.
Appreciate it.
Awesome. Thank you so much.
Sure.
Thank you so much. That's really good. All the nurses